Hello, this is Be Well with MS, the podcast that brings real talk, expert insights, and uplifting stories for people living with multiple sclerosis.
Welcome back to Be Well with MS podcast. I'm your host, Dr. Agne Straukiene, neurologist. Today on Be Well with MS, we are diving into a very important and often misunderstood topic. What does it mean, aggressive, highly active, highly evolving multiple sclerosis? To help to explore this, I've got a guest speaker, truly exceptional neurologist, Dr. Antonio Scalfari, consultant neurologist, researcher, nationally and internationally recognized expert in multiple sclerosis, and in particular in progressive MS and treatment strategies. Dr. Scalfari is based at Imperial College of London. That is his main academic base, where he works and helps to redefine how we understand the trajectory of MS from early relapses, disease activity to long-term MS progression. And the concept of smoldering MS, a form that causes subtle ongoing deterioration that often escapes the detection by using the routine conventional investigations. And we call this real MS. His research has contributed to international guidelines and continues to shape the way we classify and treat multiple sclerosis, active and fast-moving forms of the disease. In addition to NHS and academic roles, Dr. Scalfari also provides private neurological care at Harley Street and Doctoral London clinics in the centre of London. He's seeing a wide range of the neurological conditions and has gained a lot of expertise. So, in this episode, we will unpack the clinical and biological meaning behind the terms like highly active, aggressive, and rapidly evolving MS, and explore how neurologists identify these patterns and discuss why early, high-effective treatment can make all the difference. Antonio, welcome to this Be Well with MS podcast for the second time, and it's a real honor to have you again. For the listeners, if you missed the first episode with Antonio, we have recorded years ago on our previous episodes, and we discussed the slowing and reversing MS brain aging process. So if you missed that, you need to go back and listen to this first episode. So welcome to this podcast, Antonio.
Thank you, Agne. I'm very happy to be here for the second time. Your very well-known podcast is giving me this great visibility in the MS world, and I thank you for including me. So very happy to address the topic, the very interesting topic that you lay out, and you made a very good introduction. We're going to talk about aggressive MS, how to define aggressive MS, how to distinguish this from highly active disease and its relevance to the therapeutic management, and also in the context of the emerging concept of smoldering MS, as you mentioned.
Absolutely. I think, Antonio, without any further delay, we need to dive into the questions that I have prepared for you, and everyone is listening us and would like to understand. Maybe to start with definition, what does that mean, highly active MS in clinical practice?
Well, a highly active MS, to define an aggressive disease course predominantly based on the focal inflammatory parameters. So the occurrence of relapses and new MRI activity. As we all know in the world of MS, relapses and new lesions detected on the MRI results from the focal inflammation, which is one of the pathological hallmarks of MS. And therefore, the occurrence of new focal inflammatory activity distinguish those patients who have highly active MS. There's another subgroup of patients which are slightly different from the highly active MS patients, which is called rapidly evolving severe MS patients, which are distinguished by equally aggressive disease course since the very beginning without trying any treatment first. So the main distinction between highly active MS and rapidly evolving severe MS is the occurrence of a lot of relapses and new MRI activity. In the first case, despite having a treatment, so failing to respond to treatment. In the second case, the rapidly evolving severe MS, disease activity occurring early in the disease course when yet patient has not accessed any treatment. But basically, they both refers to the same type of disease activity, which eventually leads to the rapid development of severe disability.
So it must be devastating for people, but in the world of MS in 21st century, we have some medicine that could potentially help for people in this situation. Just to summarize, so somebody who presents with 2 or more relapses in 1 year, and Antonio, correct me if I'm wrong, and having changes on the MRI scan, whether that shows enhancement of gadolinium, which is a contrast, or patients who develop a significant lesion load in a short period of time, people who had already treatments or who never had exposure of the disease-modifying therapy, these are classed as a highly active, rapidly evolving. There's different names to describe but that indicates that people require an immediate interventions to help to preserve their brain health.
But back to the point you raised, a lot of studies have shown that when the brain is exposed to this storm of inflammatory activity, it's very likely to set up a sort of cascade event that eventually might lead to, down the line, to develop severe disability. So as you mentioned, it's very important to recognize this very early in advance and address it therapeutically by tackling it aggressively.
Yeah, so defining the subtype or form of MS allows us to implement strategies and quite soon. And I guess that's very helpful for us as clinicians to have some definitions like highly active MS, because it helps to stratify and apply some different pathways that we would normally do for somebody who had maybe 1 relapse in 10 years. So that highlights a lot of red flags on our healthcare systems that we need to do and manage these people differently. And also looking at the biology level, there are some biological markers that we can check these days, and it's emerging field, which is neurofilament level, for example, in the serum and CSF, which indicates an active disease. Would you like to delve a little bit on the biological markers? What do they mean, and what do we test these days, and why do we do this?
Well, yeah, that's a very relevant point. Historically, MS histopathology has been focused on focal inflammatory activity, and that's why we tend to define, since the very early stage, the disease activity based on the occurrence of relapses and new MRI lesions. However, our understanding of the MS pathophysiology has dramatically expanded, emerging evidence on the role of other mechanisms that goes beyond the focal inflammation. So we shed light with a lot of emerging new study on what is causing the disease progression in addition to the focal inflammatory activity. And that is reflected with the broadening of the definition of highly active MS, or even we're going to discuss later, aggressive MS. And this broadening of the definition implies including other parameters, as you mentioned, so classically serum biomarker. One of the most commonly used that is receiving increasing focus and attention is the level of neurofilament. Neurofilament is a general biomarker that expresses damage in the neurons, in the nerve cells. And therefore, if we do see an increased level of those filaments in the serum, in the blood of patients, that implies that there is an ongoing damage, and that can reflect a very active disease, aggressive disease. So in addition to people who also have a lot of relapses and new MRI activity, having a dramatic increase in the level of neurofilament in the blood can be an indicator of aggressive disease course that requires an early aggressive therapeutic approach. But I think also the definition of highly active MS is broadening by including also other MRI parameters beyond the accumulation of the classic lesions. An emerging radiological marker that distinguishes patients with a more aggressive disease course is the occurrence of rim-enhancing lesions, or otherwise called slowly expanding lesions, which are lesions in the brain that behaves differently from the standard lesions, because in contrast to the standard lesions, once they occurred in the brain, they start like shrinking as a result of the inflammation that gradually subside. this subset of lesions actually have a tendency of expanding. So it's a completely opposite behavior. And expansion means continuous ongoing brain tissue destruction. And hence, that clearly characterize those patients who are experiencing a more aggressive, more active disease course. Hence, it makes a totally sense, including this imaging biomarker in the new emerging definition of a highly active MS.
Okay, Antonio. So it's a lot of information for people, and I just want to digest some of the complex definitions that you used. So imagine that neurofilament is one of the biomarker that we in our clinics, MS clinics, and I like the MS nurse of mine who uses that analogy to say that neurofilament is like a broken wires and lines, and you got this kind of debris of copper around that broken area. So that's the neurofilament. So it's an active marker of the active neuron and nerve injury, axonal destruction project in other scientific language. And then Antonio mentioned about the slowly expanding lesions, which is a feature on the MRI scan. Also, we have paramagnetic rim lesion, and the thickness of this around the rim that surrounds that inflammatory process also is classed as one of the radiological biomarkers, indicating that there is an underlying slow progression. And I guess we are going into this another definition that we mentioned at the very beginning, which is aggressive MS. So shall we start with explaining what is the aggressive or malignant MS? What are the mechanisms behind, and how do we define the aggressive? And what's the difference between the highly active versus aggressive MS?
I think there is an overlapping between highly active MS and aggressive MS. They belong to the same, let's say, umbrella of very rapidly evolving disease. I think the main distinction, the main difference between highly active and aggressive MS is that aggressive MS is defined by the rapid development of disability, irrespective of whether patients are also having a lot of focal inflammation, florid inflammatory activity, which is mainly the distinguishing feature of highly active MS. It must be said that defining aggressive MS is quite challenging, and there hasn't been any consensus so far. There's been also an important committee meeting, which was led by ACTRIMS a couple of years ago, and it was aimed specifically at can we have a consensus of defining aggressive MS. But unfortunately, consensus wasn't reached. And I think the most commonly accepted definition of aggressive MS is when people do reach severe disability milestone within a short time, relatively short time. One of the most commonly used definitions is when people become so disabled to require unilateral assistance for walking, which marks the attainment of 6 of the ESS scale, within 5 years from the disease onset. So very aggressive behavior, which leads to the unusual fast attainment of severe disability. But obviously that can coincide at the same time also with a lot of relapses and a lot of new lesions on the MRI. Probably biologically, if we look more specifically, when we look at aggressive MS, aggressively results into development of disability because of progression independent of relapsing activity, let's say. So as a result of progressive disease rather than as a result of relapses, and that is more typical of a highly active MS. So I think that biologically, if we want to really distinguish the two entities, which nevertheless tend to overlap a lot each other, I think that's the main distinction.
Yeah, so just to emphasize what Dr. Scalfari just said, highly active MS tends to be more defined by typically referred to relapsing forms of MS, but then aggressive is more so with early onset of the progression. So that's the key difference. There is also a difference at the biology level, highly active MS and aggressive MS. So it tends to be that with aggressive MS and malignant MS, there are some premature B cells. As we know, our immune system consists of various different immune cells. We know that there are main T cells and B cells. And imagine that B cell is one of the sort of students at school that if the mature cell is functioning well, so they had all the proper education, and if the immature B cell didn't have a proper educational system, skipped the lessons, didn't attend school, so their education around the immune system and how to fight against the bacteria and viruses is disrupted. So therefore, it inappropriately starts targeting our brain cells by causing more inflammatory process, and the progression quite often not reversible. So once the relapsing form changes to progressive MS, so it's really difficult to regain the function. And quite often people with aggressive MS, they tend to undergo hematopoietic stem cell transplantations, where highly active MS, they are getting highly active potent drugs to control the disease progression. And I guess there are some other biological markers to define the aggressiveness and very active MS, and progressive in particular features are being captured by doing the GFAP marker. Would you like to explain a little bit on the GFAP?
GFAP is the new kids on the block, basically. It's one of the newest biomarker that is currently being used to monitor the disease activity. It's got potential to be more specific for MS compared to neurofilament level. And obviously a sharp increase of the level of GFAP in the serum, as well as in the CSF, in the spinal fluid tap, can be associated with a more aggressive disease course. So certainly that is one of the marker that is receiving a lot of attention and focus as a potential indicator of more aggressive disease course. One that probably we didn't mention so far is the possibility of recovering from relapses, which poor recovery from relapses is certainly one of the distinguishing features that patients experiencing aggressive disease course. As we know, relapses, especially early in the disease course, despite being a very dramatic event for patients, tend to then gradually improve. And especially early in the disease course, most of the patients then recover completely and fully from an inflammatory attack. In contrast, when people unfortunately experience an aggressive disease course, one of the distinguishing features is the lack of complete recovery from the attack, which probably is mirrored biologically by somehow impair remyelination efficacy, which doesn't allow the brain to repair the ongoing acute damage. For some reason, patients don't remyelinate as much as others. And that is why they experience such an aggressive disease course. And I think in this regard, it's extremely important to identify these red flags, indicator of aggressive disease course, for timely implementing the correct therapeutic management. So after years of stability, one thing is like try to identify since the early stage of the disease whether the patient is at risk of experiencing one of those aggressive forms of MS. But also we need to be wary of the possibility that sometimes patients, despite a long period of stability, eventually go suddenly down the hill, and a very aggressive or highly active disease course may suddenly emerge, which has to lead changes in treatment in order to avoid any further deterioration and any severe consequences, such as accumulation of severe disability.
I think we are in the new transition and moment that quite often in MS we would fail to regenerate the cells. Today, it's been published on the Brain Journal, Plukino's lab outcomes, that they have discovered that stem cell graft, which is injected into mice animal study at the moment, it regenerates the myelin, and that a really huge hope for MS community that remyelinating process in the MS, particularly in the progressive MS, is revolutionizing the whole care that we provide to people with MS. And I think this is really great news. Have you seen that?
I did read it. It's very promising, and I think is a huge step towards then doing clinical trials in human beings. And this is one of the classic questions that obviously patients are asking in clinic, understandably. The hope is not to try to stop any further progression, but actually to repair what has already been damaged.
Yes.
So hence the very large focus on remyelination. And the new study from Cambridge seems to suggest that this is feasible at some point. So a lot of enthusiasm. It's certainly feasible in experimental model, in animal model. And obviously now the next step would be to translate this into human beings, and it would be very exciting. So I definitely agree. As I mentioned earlier, remyelination is one of the most important features that can protect from highly active or aggressive form of MS. And another important biological marker is also, as you mentioned earlier on, the role of B cells, which in my view has been the emerging key player over the past few years that led to the development of the most modern treatment approach aiming at depleting the B cells. And I must say, at the Imperial College where I work, there's been a lot of very nice studies quite a while ago showing that, in line with what you said before about the role of B cells, those people who tend to experience more aggressive disease course are distinguished histopathologically by B lymphocytes aggregates in the meninges of the brain. That was an amazing study which was led by one of my colleagues, Roberta Magliozzi, back when I was doing my PhD at Imperial, and then has been confirmed by other labs. So apparently this patient had a very aggressive form of MS. They managed to find out specific aggregates, which called follicles of B cells in the meninges. And those who had these aggregates actually had a much more aggressive disease compared to those who did not have aggregates. And that further highlights the importance or the key role played by the B cells, because these lymphocytic aggregates are mainly formed by B cells itself. So as an important biomarker of aggressive disease course.
Yeah. So the B cells, when they group up, it felt like in the army, like when they go to fight, they like to stay together. And that's where the whole power comes from. And that's a form of more highly aggressive.
Yeah, exactly. Because the underlying hypothesis that by grouping, as you said, as by
Teaming up.
inside the brain,
Yeah.
in a chronic inflammatory status that characterizes that leads to the continuous deterioration. So that's the biological explanation of it.
Yeah. And I just recently, just before our interview, I read a new article from University of Innsbruck. Actually, I spent a bit of a time down there years ago when I was just a neurology resident. So they just published on MSJ that there is another player as a biomarker, kappa light chain. And this player is one of these new diagnostic markers in multiple sclerosis. It's been, advertised at ECTRIMS in 2024 as it could perhaps replace soluble bands. And at our MS service, we're looking at setting up the kappa light chain markers as part of the diagnostic pathway. And what the study of Innsbruck shows that if the kappa light chain marker is elevated more than 100, so there is a likelihood that people will develop progressive MS in 10 years' time, excluding all the disease, type of the drugs that they were before, age, duration of the MS disease, all that excluded, and they can predict that having raised kappa light chain marker indicates that people may tend to have more progressive forms of MS. What does that mean in a clinical setting? We would probably treat more aggressive people who's got increased marker. And to give a metaphor just on the spot, creating this one, imagine that the kappa is one of the string of the instrument and there is an orchestra playing music. And if one instrument is out of tune, so that takes the whole immune system disarranged and it becomes so active and targets the brain tissue by causing more inflammatory demyelinating processes with a degeneration that people end up in having brain volume loss, progressive symptoms, progressive MS requiring walking aids, etc. Now, Antonio, let's move into a more beautiful metaphors to explain complex medical definitions to layperson audience, and that's the majority of our Be Well with MS, or people with MS or carers listening to this podcast. Could you use a metaphor to explain what's happening in the brain during highly active MS? What's underneath the whole scenery?
Well, it's a nice question. I like to think the brain as a sort of vast forest with countless trees. And we may think about trees like representing each one some nerve cells. So the forest gives you this feeling of calmness, healing, like a nice, safe place, right? Self-sustaining all at once. So causing this very florid burning of those trees, which represent the neuronal cells, I would say, start spreading throughout the forest, causing then eventually a lot of damage, leaf scars, and weakening the whole forest, therefore the whole brain tissue, increasing then the risk of collapsing and causing permanent deficit. That's, I think, it's a metaphor that probably explains the way I see highly active MS.
This is
So important. It's important to tackle those fires before they spreading too wildly and tackle them aggressively, which is the reason why we want always to implement a very aggressive therapeutic management, especially among those people presenting with rather aggressive disease features.
This is so beautiful. Thank you for sharing this metaphor. I think that resonates with many people, and people when they are making decisions towards the disease-modifying therapy, whether to start at all or not, or which medicine to go. I think that visualizing that forest and Dr. Scalfari that just described that whole scene of the activity will shape the informed decisions. Now, let's move on to, can someone appear very stable with EDSS 0, nothing is wrong with them, but still have aggressive disease under the surface?
I think, yeah, because that's the way, it's all depends on how you define aggressive MS. If we use the traditionally used assessment tools, if we look at simply at the occurrence of new lesions on the MRI, whether or not they're having relapses, or whether they are stable on the EDSS scale, those are parameters, tools that are commonly used to monitor the disease, but do not necessarily catch the whole wide spectrum of symptoms related to MS or biological activity related to MS. So it's not uncommon to see people who are seen stable according to those specific parameters, but yet under the surface, they're still having very active disease. And that reflects our clinical practice. I think with the widespread use of very powerful disease-modifying treatment, which in most of cases succeed in suppressing relapses, suppressing any new MRI activity, making these patients relatively stable with no advancement, no progression on the EDSS score. And despite we reassure this patient that everything looks stable according to those parameters, yet they come to us and say, I'm not feeling well, I'm feeling worse. And the problem is that defining worse, because worse is probably driven by an underlying biological activity which is not traditionally detected with our tools that we implement in clinical practice. And so when we dig further and we look more carefully among those patients, we might end up finding increase, for instance, neurofilament level, or a larger proportion of slowly expanding lesions that reflect an underlying ongoing biological activity, which can account for the continuous progression, continuous aggressive disease course, despite the fact that from the focal inflammatory parameters, the disease seems to be completely stable. So to answer your question, yes, among those people who seems to be stable, there can still be a lot of activity that reflects an aggressive disease course. I think that's mirror the classic emerging view of MS, if you want to do a metaphor, as the iceberg. What we see on the surface is just the tip of a huge iceberg underneath the water surface, right? The tip of the iceberg reflects what is more easily detectable in MS, which are the relapses and the focal inflammatory, focal new lesions on the MRI. But underneath the surface, there's certainly an ongoing smoldering activity that somehow other people have defined as a silent progression, which accounts for a gradual decline of the patient's both physical and cognitive function, irrespective of what we see on the top of the surface or on the tip of the iceberg. So I think that's a good metaphor to describe this sort of dichotomy, contrasted dichotomy. And that's also to reassure patients that they are not making this up, that they are actually getting worse. We understand that it's true. There is a biological explanation for that, despite according to the standard parameters, we don't see any disease activity.
Your voice matters. What you're saying about the progressive MS, we do truly believe. If anybody works in multiple sclerosis, we all on the same page, we all understand the underlying pathologies of clinical worsening, not necessarily visible on MRI scan, but there is underneath the water, as Antonio described, a lot of activity that not necessarily we see that on conventional MRI scan. And a lot of people now listening to this episode and saying, Agnes, stop it. How much more information you're going to give? What's wrong with me? Like, let's give people some hope and talk a little bit about the treatment and moving us forward onto high efficacy treatment options. When do you consider choosing the high efficacy drugs in people with MS?
Well, yeah, that's a very relevant question to all our patients. And I agree, I don't want to give a complete negative outcome here. There's a lot of hope. We learn how to address this proactively and how to make a difference. And that implies the use of highly active treatment. I think my treatment philosophy is to treat aggressively in most of cases, regardless whether patients are presenting with aggressive disease course. But of course, especially among those exhibiting more florid inflammatory activity. And the biological rationale, as I mentioned early in our discussion, is that it has been proven that if you let those fires still breaking in the forest, they trigger a cascade of events that eventually will lead to the total collapse of the forest, hence the brain, later in the disease course. So it makes totally sense aggressively tackling early those mechanisms in order to avoid rapid degeneration that can occur also years later. So the implementation of an aggressive therapeutic management implies the use of highly active treatment, and thankfully our therapeutic landscape has dramatically expanded, so we can use now very powerful and at the same time very safe drugs after all. And that's reflected by the increasingly large use of highly active treatment among most of patients. At least in my practice, we tend to use highly active treatment in most of cases because they're safe nowadays. So it makes sense playing your best card since the very beginning. But also among those who are not being given actually highly active treatment, we always have to be wary about the possibility of the disease rapidly declining at some point, as we mentioned earlier, or being able to detect all those red flags that might imply the disease is changing in its behavior, and therefore changing also accordingly a therapeutic approach by escalating into a stronger compound, into highly active treatment. And by doing so, I must say, we always succeed to prevent any cascade of events that can have a very disastrous consequence down the line by determining an irreversible damage.
Totally. And I think it was sprinkled just with the water gently, so that's a mild treatment. For some cases, it's still suitable and it's okay, but if the biological markers and radiological markers are not showing the risk of progression and aggressiveness of the disease, it's fine. But for the aggressive, highly active MS, you want to combat the fire aggressively, and because it's just a smolder out of sight, creeping under the ground and actually destroying the roots of the forest, it's very important to tackle that in a timely manner to preserve the brain volume, the brain health, the cell function. And don't forget lifestyle. So besides all the highly active treatments that we have, you are creating the soil to seed a plant if only you practice healthy living, healthy lifestyle. So if you're still continuing smoking and listening to this Be Well with MS, by definition, the title, you can't smoke and listen Be Well with MS at the same time. Some people do, I appreciate, but really seriously consider this is the only one thing that you could do to preserve the brain health. Start now. Now, I would like to learn from your day-to-day living and being a practicing neurologist. So when we use the terms to describe what's going on at the bedside or in our outpatient clinics, how do you approach people to avoid any fear and urgency that something is wrong with them? What's your description. So maybe this is a message to the nurses and other healthcare providers who are going to learn from you. So how do you approach people to describe that this is serious? We really need to do something more actively and urgently.
This terminology can be very scary. And I agree that often patients come to me, do I have aggressive MS? Do I have highly active MS? And SPMS, sometimes they stack also into other definition that is related in their mind, in people's mind, to poor outcome. Personally, I don't like applying labels. It's something that I don't use in clinical practice because of the potential emotional impact that this type of terminology can have on a patient whose psychology is already strained by the burden of living with MS and so on. But to be honest, I tend always to reassure patients that I tend to prefer to use the terms of red flags. Red flags is a bit more reassuring in my view. So something that might flag it up, but we're still on time to catch it on time and being proactive about it. So when I see red flags that might imply a highly active disease course or an aggressive disease course, I discuss it with the patient. I explain the biological rationale that support the use of tackling this aggressively with highly active treatment. I try to make myself clear and reassure that in most of cases, by doing so, we succeed in suppressing that activity that can potentially lead to severe consequences.
Beautiful. I think, imagine your nervous system like a road network, busy with cars, people, animals. MS can cause cracks beneath the surface on the road. And you may not notice initially, but your markers and MRI scan shows that. So trust your healthcare provider who advise you that perhaps taking a bit more aggressive approach and highly active treatment is your way forward, because it really reinforces that keeping the traffic under control and flowing smoothly without having any cracks to continue your journey living with the long-term conditions such as MS.
And I must say another analogy that you made me thinking. Sometimes people come to me and they exhibit some marker of aggressive disease course despite not being clinically stable. So they are stable, but the MRI keeps accumulating lesions. There's increased serum level of neurofilament. And the way I tend to convince them that something has to be done about it, I say, imagine your brain like a very solid wall. And in this wall is constantly punched, and you might feel it's super solid. You're not having any new symptoms. But the continuous punch of this wall eventually will lead to cracks to appear, no matter what. So if you don't stop that punching, regardless whether it's causing symptoms or not, eventually the wall will collapse. There's no doubt about it. And most of people tend to get this message and understand it, so they like this type of analogy.
This analogy speaks to hidden damage and early interventions and long-term stability and good quality of life. Before we wrap up, I just want to ask you, could you share a clinical case that taught you something valuable about managing highly active MS?
It's always in my mind the case of one of my patients, a lady who was very worried about MS because unfortunately she was hit quite hard. She had accumulated quite substantial amount of disability in a relatively short time. She was requiring walking assistance because of weakness on one side. We try few treatment, we never succeed in stopping the MS from progressing. So one of those very aggressive form of MS. And I think we managed to catch it on time before it was too late. We gave her hematopoietic stem cell transplantation, which we didn't hesitate too much. And I think that's the lesson I learned. Do not hesitate until it's too late. And as a result of the transplant, she was very brave because we're looking at the time when the transplant was not, I'm not saying now it's commonly used, but it's more widespread use than before. At the beginning, was really an experimental approach some years ago. She was very brave during this treatment. And eventually, as a result of this, she experienced a remarkable improvement after the transplant. By the time I saw her again after the procedure, she was able to walk independently, and that really struck me. I left her that she was needing to rely on a cane for walking, and now she was walking without any aid. And she was smiling, and she thanked me so much. And to me, it was a big learning point, how important it is to address appropriately any disease activity, any red flag activity that might predispose into a very negative outcome. But if it's taken into timely manner, can really be addressed efficiently, and the worst outcome can be very effectively avoided.
Such an inspiring story. Thank you for sharing this. And I just want to quickly ask you, what is the quick criteria for hematopoietic stem cell transplantation for people who are listening to this episode?
The hematopoietic stem cell transplantation remains an experimental approach. So it's not an NHS England approved treatment, that to be made clear. But over the years has become much safer to be used. So there was a lot of concern at the beginning whether using this approach, which might bear some important side effects. The criteria to provide this to patient is when, despite having tried one of those aggressive treatment approved by NHS England, so the monoclonal antibodies, despite that, they're still exhibiting aggressive disease features with florid inflammatory activity. So despite being on treatment, they're still having a lot of relapses, new activity on the MRI. Hence, that defines a treatment failure on standard therapeutic approach. And it makes totally sense trying the hematopoietic stem cell transplantation.
Wonderful. I learned a lot during this episode. I hope that our audience learned too. So as we wrap up today's episode, I want to leave you with this thought. Just like a candle can light another without losing its flame, sharing knowledge and hope makes us stronger, makes us together. MS may be unpredictable, but your journey doesn't have to be walked alone. You have choices, you have strength, and most importantly, you have time to take action. So early, informed decisions today can shape your future, and I hope it's going to be much brighter. So Antonio, our conversation today for me was like a gift. I really enjoyed our conversation. I think we brought a lot of thinking to our audience and a lot of visuals and metaphors to explain the complex underlying pathology of aggressive and highly active MS. Thanks for joining me today.
Thank you for having me.